Now we are turning to quite a different subject. We're going to hear from Simon Tagg about puberty blocker use in New Zealand, and whether this is a case of over-medicalisation or unmet need. Simon's a software engineer with an interest in evidence-based medicine. He founded the Fully Informed group in 2020 to scrutinise the use of puberty blockers for paediatric sex change modification in New Zealand. Welcome, Simon. We're really keen to hear about your research.
Thanks, David. And I'm assuming you can hear me right now. So yes, I'll be talking about the sort of usage of puberty blockers in New Zealand. Fully Informed is a group of medical professionals, policy people, legal experts, and parents. And so there's a bit of a play on words, is that fully informed is the right. Health consumers in New Zealand have the right to be fully informed about the treatments that are being suggested, and it was also that we sort of take a very kind of detailed look. So what I do is I make a lot of I'll use this acronym OIA, which is the Official Information Act. I make a lot of OIA requests to different government agencies to try and find out more detail about what the situation here in New Zealand is. And so one of those agencies is PharmAC, which is the National Drug Purchasing Agency for the New Zealand health system, and they provide good detail on different drugs and like how prevalent they are in usage. So we're going to drive like right into sort of one of the main charts, and this is from some of that research. So this is a chart that plots the usage of puberty blockers for a particular age group, for 12 to 17 in New Zealand, from sort of the early sort of 2006 right through to quite recently, and it's compared with the usage in England and Wales. So the England and Wales figures come from the NHS. We do have sort of some earlier figures from the NHS, but it's easier just to show this one from a particular data source. This is from their recent consultation on the use of puberty blockers in that jurisdiction. So obviously you can see that has sort of increased quite rapidly, and we're now looking at about just over 400 12 to 17-year-olds being treated with puberty blockers, and roughly the same number, I think it's 378 in England and Wales. And so there's a particular reason why this age group I've chosen this age group to present, because it has other indications. Puberty blockers are used, the same drug is used for prostate cancer and endometriosis in adults, and then it's also used for short stature and precocious puberty in young people. But normally that finishes up by age 12, and so the use of this group here will be very, like the vast majority of it will be for gender dysphoria. So obviously there's those figures are sort of roughly comparable for England and Wales, and obviously England and Wales has a much larger population of adolescents. So if we put that out by rate, the next chart you can see this is now by rate, so per head of this is now per 100,000. So New Zealand figures is roughly 110 per 100,000 in the most recent time period, whereas England and Wales is about 10 per 100,000. So that works out to be, one way of thinking about it is 0.1% of the adolescents in New Zealand are being treated with this drug, which is really sort of like one, sort of averaged across high schools, that's sort of one person in a large high school. Or if it's, although there's going to be regional variation, so there may be high schools with 2 or 3 being treated sort of on average. And so now there's this question, there's a bunch of questions that fall out of this chart, and those questions will structure the rest of the talk. And so does this, I'll just show another slide just to sort of show another chart. And so now this is back to treatment prevalence, absolute numbers. And this orange dashed line here is the usage in 9 to 11-year-olds. So 9 to 11 is still in an age group where it may be being used for short stature or for precocious puberty. And so you can see that that has increased as well. And that had a sort of, prior to the sort of really emergence of its usage for gender dysphoria in the 2000s, it had a usage of about 40, and now it's increased to, and this is a separate quest, to about 100 and 160 in 2020. So some of that has also risen, and so I think that some of this rise is also that it's increased for precocious puberty and short stature, but some of that rise is very likely to be also usage for gender dysphoria. So really the sort of total usage for gender dysphoria is probably slightly higher than this red line. And I think what may have happened is its usage for gender dysphoria has sort of cross-legitimized its usage for these other indications, which are, it's not entirely clear that that's a good situation for those as well, but that's not going to be the topic of this presentation. So there's some obvious questions here. So first question is, why is it so much higher in New Zealand? What are the consequences, and is this over-medicalization or unmet need? Because you might approach this question, you might approach this chart, if this is the very first time you've seen it, and you might say, well, this dot down here, this usage in the UK, that might represent sort of an appropriate usage, and this excess here is over-medicalization. It's a bit more complicated than that. And the clinicians themselves in New Zealand would say that what they're doing is that the UK has sort of unduly restricted the usage of puberty blockers, and actually in New Zealand we have, it's more appropriate is to be treating 0.1%. Now there's a couple I don't agree with that position, but it's sort of worth thinking through, like how that gets rationalized, or the structure of that argument. So we'll look at that as well. So why is it so much higher? There's some other secondary questions, like how did I calculate this, and what are the prospects, and those might come up in the question time. It's just there isn't enough space to do that. So why is it so much higher? So there's really sort of one thing I'm going to focus on mainly here, which is the top one, is that it's in New Zealand, it's delivered through the primary care system, and there's less bottlenecks. Jan touched on a bit of this in B. So the policy context, there's very lax oversight, and I'm not going to go into much detail there. So there's really sort of one thing I'm going to focus on mainly here, which is the top one, is that it's in New Zealand, it's delivered through the primary care system, and there's less. And then there's also there's also, New Zealand has some differences between overseas about how that sort of oversight might function in a broader context. So less bottlenecks, and let's look at the primary care delivery. Okay, so I've made this sketch here of how it works. And then I haven't got a picture for this, but you might compare this to the Tavistock situation, if you're familiar with that. I might describe that as well. And we'll come. There's a few parts to this diagram, and we'll come back to it as the presentation proceeds. So I've sort of sketched this out in terms of on the vertical axis, like a more affirming, or what I'm going to describe as more scientific approach, and at the bottom I'm going to have a more scientific approach. And so there's clinics and youth clinics and gypsies, which are GPs with a special interest. As a GP, you can train to specialize somewhat, and so there's GPs who specialize in gender medicine, and also sexual health clinics are really sort of the core initial people who would have set this up in the 2010s, early 2010s. And there's a sort of a pathway here of a referral to a psychologist, or not, maybe a referral directly to an endocrinologist. We'll talk about that a little bit. The endocrinologist will do the first injection of puberty blockers, and then generally it'll go back to the sort of arrow down in the corner arrow there I've got in the top right. the following injections after the first will be managed in the primary care system, managed in the local clinics. So this is based, this sort of diagram is based on conversations with a variety of medical professionals, so psychologists, psychiatrists, GPs, secondhand through to endocrinologists and other people who have an interest in the health system. There's also a bit of a pathway towards a non-medical pathway, but it's very chancy. I've sketched that out at the bottom here, where you may get a therapist who is more skeptical about gender identity, and they may continue with a sort of psychosocial approach, but it's quite a fraught situation generally. So the first thing we're going to talk about is this sort of this axis along the top, the sort of more scientific and more scientific, and I think this was sort of mentioned here. So this is an article from The Guardian very recently, and it describes what's happening with the situation in NHS. So they've decided to restrict puberty blockers to medical trials, and they're going to set up a new sort of gender identity set of services to replace the Tavistock. So that is, and you see from the highlighted text that there's disagreement around. There's this. It's very hard to get to a middle ground or a consensus around from these two perspectives. And so I thought that was a sort of quite timely article, and it does sort of speak to the situation in New Zealand as well. So I've described this as, there's this sort of other speakers have talked on about this, that there's these ideological divide here. And I put this kind of this background here of geological layers, because underneath a dispute about is it unmet need or is it over-medicalization, is this ideological dispute. And so the bottom layer of this geology really is about epistemology and uncertainty. The next layer up is around the etiology of gender-related stress. Why do people feel that they need medical intervention to change their bodies? And then there's a sort of a notion of harm. So there's different perspectives on what is harmful. So we'll just dive into this, and then I'll bring it back to some applications or some other aspects of what's going on in New Zealand. So there's these two perspectives here, and so if you're familiar with evidence-based medicine or the scientific approach to things, that there'll be that you can probably guess how I've arranged this. That there'll be this hierarchy, so it's really sort of increasing confidence as we go up the hierarchy. So a systematic evidence review is sort of regarded as the procedure that produces the most high confidence knowledge, and then there might be randomized controlled trials, and there might be observational studies of different measuring different outcomes. At the bottom of that hierarchy is the subject self-report. So it's the scientific approach does not really. I mean, it might be a useful starting point, but a subject self-report, or in this case, a child self-report about their own experience, that's not regarded as a source of truth. It might be notable, or it might sort of start where things are, but it doesn't tell you much. Next, also what the scientific approach is clinical experience, because in the history of medical scandals, it's always sort of relies on a clinician thinking that they had the right approach based on just their experience, but their experience can be biased in various ways, such as they don't do follow-up, or they see a particular presentation at their clinic, or they've invested their reputation or sometimes their business interests in a particular treatment. So we tend to sort of include it but discount it in the scientific approach. Now, over on the right, I sort of present what I'm calling the scientific approach. And in this approach, the subject or self-report is the top. And there was a very just the other day, there's an article from Jennifer Block in the Boston Globe, and she interviews Jason Rafferty, who's the one of the architects in the US of their gender affirming care approach, and he talks about this explicitly, that if somebody says that they're X, that's how they orient the whole treatment program around that assumption. So I don't think I'm being unfair when I put this at the very top. And they also highly value clinical experience. And then if they do other studies, it tends to be quite questionable studies, like data mining. So in New Zealand, we have the Counting Ourselves survey, which is really just a large internet sample survey. It's not representative. And then I've put in sort of faded text here, the systematic review. So there are sort of systematic reviews, but on the scientific side, they don't really talk about them very much, or they don't really refer to them. And if they do refer to them, it isn't reflected very well in their guidelines. So there's quite different, in fact, very opposite approaches. There's also how you treat uncertainty is it's been a strong interest of mine. So in this over on the left hand side, we have this report from the Clinical Advisory Network of Sex and Gender, and they discuss how, like, one thing that's uncertain is the effect of puberty blockers on the developing brain. And so there's animal studies, and a lot of those animal studies are highly suggestive, or in the animal study, there's permanent effects on cognitive function if you block puberty. But those studies aren't, because it's animal studies and maybe a case study, those studies aren't strong enough to say with certainty that this will happen in adolescents as well. But the treatment of that is that the uncertain, if there's something that's uncertain, its underlying risk could be high or it could be low. So if it's uncertain, we still have to deal with it. It's still something that a health consumer would want to expect to be told about. However, on the scientific side, the usual approach is to collapse something that's highly uncertain with the category of no risk. So there's no mention in any guidelines or consent forms about the risk of on brain development. And there's another piece here from this is another guideline. This is for cross-sex hormones, where they actually have this headline: no increased risk or unknown. So they collapse those two together, when a more scientific approach would be to say, oh, it's unknown risk, and that means it could be higher, it could be low. And then a second thing would be, well, this is what we know to be low risk. You would split those out. Next thing is there's these two sort of theories around how, two broad theories around how why do people feel this distress, and this is really sort of covered in the CAS. This is covered in the CAS report from the CAS independent review in the UK. And over on the scientific, so I call this side the constructed self, and that we construct a self out of our experiences and our impulses. But on the scientific side, there's a concept of the authentic self, that somewhere underneath this there is a male essence in a female body, or vice versa. And so this is sort of colloquially known as born in the wrong body. And previous other presenters have talked about WPATH, and WPATH authors actually go as far as saying a gendered soul in the literature that they published on this. Then there's also another sort of thing, that this question of etiology, this question of why do people feel this distress, is increasingly even sort of regarded as transphobic to even kind of bring up. And instead, the rhetoric has shifted to the autonomy rather than discussing why it would. And so it doesn't. So it's incurious to this, and other speakers have touched on that as well. And I'll give you an example. I'll give you an example of how this plays out. So talk about, on the previous slide, there's this abuse, and other speakers have touched, like Nahui has touched on this, and Joe and Alistair have touched on this initially as well. That abuse. So what I'm not going to do is, I'm not suggesting that everybody who has gender-related distress has experienced abuse, but it does come up. It comes up in the literature fairly regularly, and it comes up in the stories of detransitioners as well, around why they decided to transition. So I'll give you an example how this plays out. This here is Dr. Jamie Veal. He is the until very recently, the president of PATHA, the local group in New Zealand, and also the WPATH secretary. And he's sort of been involved in a variety of guidelines, including the guidelines that Jan has analysed. And he's a psychology PhD. He's not a clinical psychologist. He's the non-clinical sort at Waikato University. And this was so he's sort of had this initially in his sort of academic career. He's had this interest in like this question of like what are the causes of gender-related, what he calls gender variant identities. And in his PhD thesis, he actually finds that there is this relationship, like possible relationship between abuse. This is in this case emotional abuse and having a gender variant identity. Since that time, he hasn't really focused on that aspect at all. He's focused on the sort of reverse causality that gender variant people are the target of abuse. So gender minority stress theory. But in his original work as a graduate student, he did actually find this relationship. So this was a large study of maybe 2,000 people, and then put a statistical model, crunch the numbers on what that statistical model suggested would be the relationships. So that was 2011. And so now we'll skip forward into, he also cites, actually, this is another important point. This sort of touches on Nahui's point here, is that he cites this study by Devore. Devore is also another WPATH author from 1994, Transsexual Disassociation and Child Abuse. So this was interviews with 45 female to male transsexuals and the majority of them who reported severe child abuse. And so there's this quote here from Devore about the abused person feeling disassociated from their own body and seeking another body, potentially as a sort of maladaptive solution to that abuse, perhaps trying to escape that abuse or abuser. So he's very aware of this literature. This is cited in his PhD. And so we skip forward to 2023 or 2022, and now this is the draft. This is the primary care guidelines for hormone therapy, so not for puberty blockers, but for cross-sex hormones. And Jamie Veal is one of the co-authors of these draft guidelines. They've now been finalised as well. The lead author is Dr. Rona Carroll. And so there's this quote here from this. I'll bring it up, actually. This. So now he says there's no evidence that sexual abuse causes gender incongruence. Okay, so that's quite misleading, given that he found a relationship between emotional abuse and gender variant in his own PhD thesis. And then if your patient has a child, then there's these very sort of tortured sentences. It'll be important. It describes it as a complex interweave with gender incongruence, and if they have a sort of sexual abuse history. But then in the author's experience, many patients can clearly differentiate between their symptoms of trauma and feelings of gender incongruence. So it's like, well, really, can they really clearly distinguish? The next sentence sort of contradicts that, and then it says, as part of the informed consent process, check your patient understands gender-affirming hormone treatment is not a treatment for sexual abuse trauma. So they're putting that sentence in. Obviously, what's happening is that people are arriving at the clinics having been sexually abused and seeking hormone treatment as a solution for that. Otherwise, why would they have that sentence? So this is the draft, and this does not actually make it into the final copy of these guidelines. So potentially it was just too awkward to highlight this, especially given Veal's background and actually finding a relationship 10 years earlier. And then there's this notion. So there's this notion of harm, and so there's two sides really. They have a notion of harm, and that is to harm somebody is to challenge their identity, and the scientific approach is sort of the harm is really to the body. So those are sort of the deeper sort of ideological disputes around this, and that kind of covers off this side of things here. So there is, I put this bit here, incoherent muddle is in the middle, and that a politician, they'll talk a little, like often people think there's a compromise, that you can have a compromise, and I think Alistair and Joe touched on this a bit as well. But really, if you had what you end up is is that you end up with an incoherent. You're just not applying scientific principles consistently. So this is that sort of part of it, is that's where a lot of GPs are. I think a lot of the bulk of GPs are in this sort of position, and they will refer to. They will feel uncertain about what is happening, about whether the child actually needs these treatments, but they aren't very empowered to do much about that, and so they will just refer to a psychologist, and they'll refer to the psychologist to kind of cover that off, to make sure all the I's are dotted and the T's are crossed. And then if that psychologist gives a proper assessment, the GP can say, well, okay, well, I did what I was supposed to do. And that's sort of the amount of support that they have. And I'll contrast. Okay, so I'll talk a little bit about this, these youth clinics, and this is sort of really where the contrast with the Tavistock comes in. So in the Tavistock is a sort of quite a large institution. It had a head of safeguarding. It had a board of governors. The whole book, I've got it right here actually. The whole book, Time to Think by Hannah Barnes, is sort of details how the clinicians undermined the head of safeguarding, and she successfully sued them eventually, and undermined David Bell, one of the governors. But they did actually have those sort of checks and balances on what they were doing. And the New Zealand case is done in youth clinics or sexual health clinics. And so I'll give you, this is just the about displays of one of these clinics, right? So it doesn't, immediately the question is, do these people have a head of safeguarding? No. Do these people have a board that is strongly looking at the situation in this youth clinic? No, of course not. I mean, this is just quite a small scale clinic in Christchurch, and they present themselves in sort of, oh, we're being kind. It's sort of, we're in with the kids, and that's about the extent of it. So this is so Bagshaw. This is one of the clinics here, and she's been prominent in this area. She's a dame in New Zealand, and that she says that she's interviewed. And when she gets interviewed, it's also quite interesting because you'll reveal some things about how it's really working out. And so this clinic has 100 gender diverse patients, and about 65 are on puberty blockers. So that sort of tells you, I mean, 65, that's probably, in Ireland, there's probably like 10 to 20 at the very most, probably more like 10 patients in total in the total area of Ireland on being treated. But in New Zealand, at one clinic, 65 on puberty blockers. There's also 80%. So in her view, this is just her sort of reckoning that 80% will then go on to cross-sex hormones. That's a lower figure than is reported elsewhere. And I think what might be happening is there's a sort of broader application means that less go through, whereas in the Tavistock, much more restricted application means that they're sort of more certain that those people that it's appropriate. So that's sort of how that might work out, is that that you get this, that these people will then refer directly to the endocrinologist, and I'll talk a little bit about this other aspect about sort of it's optional. It seems to be optional to refer to a psychologist. So in the next slide, we have some. These are responses from some of the OIR requests. This is a document on the left. This is from the Ministry of Health in 2020. And they really sort of say, they talk about whether some require children to get a private assessment by a psychologist before starting puberty blockers or hormone treatment. This approach can become problematic. So, and then they kind of go on to say, it is important to consider potential misalignment with Indigenous and cross-cultural understanding. So they kind of imply here that you might be being a bit maybe racist, or maybe a bit cross-culturally insensitive if you refer to a psychologist. So it's optional. We should make it optional. And a potential solution is is to put in guidelines making it clear that it's actually optional to go to the psychologist. And then on the right-hand side is that, well, what happens if you do go to the psychologist? This is from Te Whatu Ora, New Zealand's national, sort of operational side of New Zealand's national health system. And they say that it's not really about assessing or exploring the background, the reasons. The psychologist does not assess, on the way they put it, the psychologist does not assess gender. This is self-determined by the patient. So there's this policy. I won't talk much about that other than they're largely out to lunch. I mean, it's an unapproved, it's approved medication, but not for this usage. A little bit about the social institutional context, and that New Zealand, there are some difficulties with being a small country. The public servants and the journalists are very young. If you get to your sort of late 20s, you often head off overseas, head off to Australia or the UK to further your career. So there's high turnover. Often you have very recent graduates in these positions, either in journalism or in the public service. And there's sort of a large section of the population has sort of got attached to this idea of kindness, but it's not really kind of the policy realities and not really at the forefront of that situation. So I've got this other bit here from I thought this was quite good, that this is Thomas Cranmer. He sort of brought up, he also writes a lot of official information requests, and one piece comes out that New Zealand, in terms of media pluralism, New Zealand ranks last in terms of media pluralism, with last equal with Turkey and Romania. And so there's on the right-hand side is my tally of how many balanced articles there's been about this issue or been about the overseas issue. These are the major New Zealand media companies. Stuff has never covered it in any balanced way. The Herald, which is NZME, did publish an editorial by Jan. I don't think TVNZ has ever covered it. Radio New Zealand has had one decent article. Newshub have had two. Listener has had two pretty good articles, but they seem to have a sort of rate of about one per year as their limit. They won't do it any more than that. So there's been no real coverage of the Tavistock situation or the high rate in New Zealand, even though I've emailed a number of journalists around this issue. So that's sort of the summary of why that situation in New Zealand. There's very little oversight and there's very little engagement from those institutions or from the media. So now the consequences. We don't have a lot of time to do the consequences in depth, but there's the sort of ABC. There's the effects on fertility, sexual function. Bone health doesn't really recover. It recovers partially under cross-sex hormones, but not fully, particularly for males, and that's in a systematic review. And then I've talked a little bit about cognitive function as well, is that it's uncertain but potentially high risk situation where there could be quite consequential impacts on cognitive function from the animal studies. A little bit about this is that there's this technique, there's this fallacy you might be familiar with, the Mott and Bailey, that they describe. So reversible, there's two interpretations of what reversible mean. Often it's described as safe and fully reversible, or the Ministry of Health did describe it this way. And that means, in the sort of layperson interpretation, is that you'll meet all the developmental, you'll come off puberty blockers and you'll go on to meet your developmental milestones. The other meaning is that there's the direct effects of the blockers on the endocrine system will reverse. That is sort of the what they now say, right? So there's this Mott and Bailey fallacy: is you make a sort of broad statement that is interpreted in a particular way. Then when you're challenged about that statement, whether it is actually reversible, you fall back to saying, oh no, I didn't mean it in that sense. I only meant it in the sense that the endogenous sex hormones will restart. And so that's what we see playing out now. The rhetoric has shifted around what actually reversible means. And there's this other, so I've brought up this, and so Bagshaw in 2020 was saying it was reversible in terms of bone health, and that's not accurate. It was highly misleading. And I'll skip over this bit. There are some sort of glimmers of hope in that senior clinical advisors have come in and they've removed this highly misleading statement about it being fully reversible. And the last sort of bit before I get into summing up is this sort of impacts on fertility and sexual function, and that is that. So one thing we are confident about is that if you're treated with puberty blockers at tenor stage 2 of puberty, which is like roughly 11 or 12 years old, it's the very sort of first signs of puberty, and then you follow that up with cross-sex hormones at say age 16, it's very, very likely that you will be sterilized. So there's a lot of this is sort of low confidence or highly uncertain because they don't do follow-up studies. But in this case, we actually do have something that we're quite confident about. So what that means is that if we have about 400, just over 400 being treated a year, that means that roughly 100 to 150 are starting puberty blockers each year. Now, if we can make some assumptions, so say in a low estimate that 20% of them are starting at tenor stage 2, and that 75% continue to cross-sex hormones, that comes out at 15 sterilized per year. In the higher estimate, say a third are starting at tenor stage 2, and 90% continue, that means 45 are being sterilized per year. So this is quite significant. I mean, people say, 0.1%. That's not, they must be very careful, but considering the impacts, this isn't very careful at all. This is quite cowboy, really. And so I'll sum up now. So there's the over-medicalization or unmet needs. And so there's really, you have to kind of go back to first principles. Is somebody, if it is unmet need, then some people must be born in the wrong body, but I don't think there's evidence to suggest that. We do have recent studies that are showing a higher discontinuation rate from cross-sex hormones and from puberty blockers. There's sort of Bagshaw here really kind of sums it up, that she thinks in one of these interviews, she thinks that you actually could be doing psychosocial first. It's just very hard to do, so she's not doing it. It's very expensive and it's time consuming. It might be worth doing, but it's hard, so she's not doing it. She also brings up the threat of suicide for that, and those are some of the discontinuation studies. And sort of rates are now reporting around between sort of 6 and 30% discontinuation rates. This is only after 3 or 4 or 5 years. You're getting high discontinuation rates. So the foundations of this analysis that it's unmet need is very shaky when you consider those rates. And you consider that some of the Dutch researchers are now saying that puberty blockers themselves may lock the person into that pathway. So if you think about this argument, it's like, really, if it is an unmet need, then we can compare to other countries. That means that in the UK there must be all these suicides happening, or in other countries. It's similar also in Finland and Sweden and the Netherlands. With these low rates, that must be producing a high rate of suicides who don't get access to the treatment. So we can do those sorts of comparisons. We can also look back in the 1990s and the 2010s to see if there really was the suicide rate from this population, and that doesn't come through at all. So that's my argument. It is a huge scandal, and if thanks for allowing me this opportunity to present these figures. I'll put out accompanying paper for this with all the references once we kind of finish this up. And I've got this. So one thing that we are doing is you can sponsor a copy of this book to go to a bunch of decision makers in New Zealand. So they'll get a book and accompanying letter to sort of highlight this and the difference between New Zealand and England and Wales.
Thank you very much, Simon. Thank you, Simon. This appreciation coming through in the chat for the work you're doing on a more evidence-based approach to this. I have a question. Do you know if the Office of the Prime Minister's Chief Science Advisor has got this on the work program at all?
Yeah, so I think we get a new science advisor every 5 years, and I'm not sure actually. It has been Julia Gerard. Julia Gerard has
Yes.
been emailed about this. It might be. I'm not sure when her term ends, but she tends to. I mean, a lot of people just sort of tend to pass it on to somebody else. The there are chief science advisors in other ministries. And so the Ministry of Health has a chief science advisor as well, and they have a sort of network of science advisors. And we do know that the acting chief science advisor at the Ministry of Health is actually very aware of this, and is now putting out an evidence brief on puberty blockers. So there is uh, some signs that there is sort of action there, but I don't think it'll necessarily come from the Prime Minister's one. They'll probably that may change in the new government. They might get asked to look at it, but at this point it's coming from the Ministry of Health's chief science advisor.
Right. Thanks. And then this question has come through. How did you get involved in this? And how can us amateurs help when the professionals have lost the plot?
Sorry, what was the last part of that question?
How can us amateurs help when the professionals have lost the plot?
Yeah. Yeah, so I am an amateur. This is just I got involved with this because I don't have a particular connection. I do have trans identified people in my wider family, but not my immediate family. Um, I do have younger relatives, who are like roughly at puberty. So I am concerned that they would that this would be presented as an option, being medicalized. But I think I guess I really is that a lot of people involved in this are parents, and I'm not a parent, and they are restricted in what they can say and what they can say publicly because they have to keep this relationship up. So I saw the situation and thought, well, I have these skills, I have a background in research and in policy. That but given the situation with parents and their restriction on being able to speak up, it needs people like me who don't necessarily have a direct connection. And how can people get involved? There's really just a lot of kind of letter writing to people, and I think it does add up, this sort of stuff. Yeah, it's letter writing to medical associations and to MPs and Ministry of Health. It does sort of add up in the end.
Thanks, Simon. And there was a note that went up quite early in your talk, and you may or may not be able to shed any light on this. Interestingly, the Rainbow Youth Guidelines for Mental Health Services are to not inquire about underlying causes and also not to use measurement tools of dysphoria. Are you able to comment at all on that?
Yeah, well, it speaks to sort of the situation in New Zealand. This is sort of Jan touched on this as well, compared to overseas. Like it's really sort of there's this sort of middle ground where you do this assessment, and then there's rhetoric around like, oh, we're going to do a proper assessment, and that can give other stakeholders sort of more confidence that the treatment is appropriate. But that in New Zealand has sort of basically been blown away, and now it's like fully captured into oh no, that would be stigmatizing. So the whole kind of Overton window has shifted into oh, you couldn't do any assessment at all, because it's not, that would be contradict autonomy, and then it would be stigmatizing. So it's kind of even people from the UK, where there is rhetoric around, oh no, it's properly assessed at the Tavistock, and it's properly assessed by these people that are involved. It's just not that situation in New Zealand at all, really.
Well, Simon, thank you so much for joining us today, for the work you're doing and for presenting it so clearly to us. And I look forward to hearing more about Fully Informed.